Gravy.
Is my screen visible?
Yes, sir. Your screen is visible, sir.
Is my voice audible?
Yes, sir. Audible, sir.
Okay. Good evening, all. Probably you can mute yourself till I ask a question. Probably mehta DNB PGs. Probably we will ask them. Probably I will ask you not to answer because you might know the answer or you might not know the answer. But I want people from DNB students or postgraduates from other institution to answer. We'll give them the chance. Okay. Vinodini, I think you can mute your mic actually. Thank you. This will be, I think I have, okay, don't bother about 172 slides. It will be about 100 slides. I will stop with 100 slides, but I need your interaction too. When question is asked, you can unmute, you can answer, and then once again you can mute. If at any point, if you are not able to understand, please stop me then and there. Okay, we will start with X-ray. Majority will be X-ray. Few will be CT. Probably only one will be an MRI. Okay, I will start now. We always have to know what is AP film, what is PA film. Less than 4 years or less than 5 years, they are used to taking supine film. That means the cassette, X-ray cassette is behind our back. They make the child sleep or lie down supine on the X-ray machine with both hands abducted. The X-ray beam passes from the anterior to the posterior chest wall. The cassette, X-ray cassette is behind the posterior chest wall. So whatever is there in the anterior mediastinum will be magnified because the X-rays hitting the anterior chest wall are not parallel when they hit the anterior chest wall. And in PA film, the cassette, X-ray cassette is placed on the anterior chest wall. The beam comes from the posterior chest wall, from behind the posterior chest wall, and then hits the cassette which is close to the anterior chest wall. Because heart is in the anterior mediastinum, the X-ray of PA view will not show a magnified heart. It will be a normal sized heart. How tissue appears on X-ray, you need to know. Bone absorbs the X-ray much more than fat. Most of the soft tissues are composed mainly of water, so it appears as shades of gray. How do they look like? From the left to the right, you are able to see hair that is jet black. Like I will show you in the X-ray, the air outside the X-ray is going to appear as black. Fat will be less denser, less darker, whereas metal will not allow it to appear as white. This is what I mean by differential tissue absorption of X-ray. What you are seeing outside, top, beyond the chest wall, beyond the shoulder. This is the atmospheric air that is black in color. But what is there inside the lungs? It is also air, but because it has to go through, it has to pass through some of the soft tissue, vascular endothelium, the pleura, the muscle, it appears less darker than the air outside. have the soft tissue, one is muscle, and another is subcutaneous tissue. The muscle appears denser, the subcutaneous tissue less denser. But you look at the bones, they are white in color. This differential absorption of X-ray by the different body tissues. So before reading an X-ray, these are the prerequisites. First, the name, age, sex, and date. Then look at whether it is penetrated properly or not, whether there is a rotation or not, whether what you are seeing is an inspiratory X-ray or an expiratory X-ray. Because expiratory X-ray, you can have the heart appearing large, the lung volume will be less, the blood vessels will be crowded. What is not there, you will think that something is wrong in the lung parenchyma. Then make sure whether there is no movement artifact and find out whether the sites are marked properly or not. These are the prerequisites before you start reading an X-ray. The phase of respiration. Normally, we expect an inspiratory film. The inspiratory film, the dome of the diaphragm corresponds to the anterior end of the 5th to 7th rib. So, you may have a confusion which is the anterior end, which is the posterior end. The end of the rib which is in close contact with the vertebral body, that is the posterior end. The free floating, like probably I should not say this, but the anterior end, it articulates with the costal cartilage. Costal cartilage will not be visible in X-ray. So you'll be able to see the anterior end of the ribs as free appearing. These are the anterior ends of the ribs. These are the anterior ends of the ribs. Normally, at least to say it is an inspiratory film, the anterior end of at least 5 ribs, first 5 ribs should be visible above the diaphragm. 1, 2, 3, 4, and 5. This is what I said. If it is going to be an expiratory movement, expiratory film, the heart will appear large and the lung fields, the lung parenchyma, the lung volume will be smaller. So we will think that there is something like atelectasis or something like infection, even when there is no atelectasis or no subsegmental collapse, because there will be crowding of the bronchovascular. Anyone who wants to talk, let them interfere. Kindly mute everyone. When I ask a question, kindly unmute and then answer. Thank you. The bronchovascular markings will be more exaggerated. There will be crowding of the vessels at the lung bases. So you may think that there is a pneumonia when there is no pneumonia. You may think there is an atelectasis when there is no atelectasis. Rotation. What do you mean by rotation? You look at the clavicle. The medial end of the clavicle should be equidistant from midline. If it is not equidistant from the midline or midpoint, that is the spine process, then you know there is a rotation. You look at this X-ray. This is the yellow line is the midpoint. You look at where the medial end of the left clavicle, medial end of the right clavicle is. You look at the difference. Because there is a rotation, the heart appears as if it is more in the right hemithorax than in the left hemithorax. You may have an erroneous impression that there is a dextrocardia even when there is no dextrocardia. So this is the meaning of whether the X-ray is taken without rotation or not. And sometimes if there is going to be a rotation, this the right clavicle is well away from the midpoint. So when it is rotated, we may think there is a node when you are going to see only a manubrium sterni. This is not a node. This is only a manubrium sterni. So that is the importance of looking at whether there is a rotation or not before you start reading an X-ray. Over or under penetration. This is a normally penetrated X-ray. That means you are able to see the intervertebral disc space through the cardiac silhouette. This is a hyperinflated lung films. It's a well penetrated, it's a normal penetrated X-ray. What is over penetration? This is over penetration. You look at how clearly you are able to see all the intervertebral disc space, how the lung fields are almost pitch dark like the outside air. So, what is there in the lung parenchyma, because it is over penetrated, you may miss out. So, this is the like side effect of an over penetrated film. Then, what is an under penetrated film? This is an under penetrated film. You are able to see the heart as if it is painted white in color. You are able to see the normal bronchovascular markings, but because it is an underpenetrated film, you will think that this child has got a bronchopneumonia. But what you are seeing is only a bronchovascular marking, because you look at all the bronchovascular markings, always it has to divide into two, because any artery branches into two. Any bronchi it divides into two. So it is going to be the bronchovascular marking what you are seeing and not the bronchopneumonia. If it is going to be an underpenetrated film, you will mistake it for a pneumonia. This is a movement artifact. If you have all double action X-rays having a double action, then don't interpret. Tell them it is not fit for radiological interpretation. Even if the radiologist gives you a normal X-ray, if you think that something is not all right, ask them to go have a repeat X-ray. Now, how to decipher an X-ray? Many a times, the books also tries to confuse you. Even in CMEs or conference, they will say, in frontal X-ray, this looks like this. You will be wondering what is frontal X-ray. It is nothing but your chest X-ray. Whether it's a PA film or AP film, an X-ray chest PA or AP is otherwise called as frontal X-ray. We'll see how to decipher. Normal thymus. This is one thing which you will be faced with, especially in less than 2 years of age. I will show you when I'll show you like a normal thymus probably later. Don't get confused by that, but I'll definitely show you. But how to decipher a chest X-ray or a postgraduate who was like me? Biscuit. Postgraduate who was like me when I was doing my post graduation. I'm not a brilliant student. I know, like a common sense pediatrician, you need to decipher, is there anything going wrong? Like if you ask the radiologist, they will say, you come from the lateral aspect to the medial aspect, don't miss out anything. But for you to interpret easily, remember three white structures. What are the three white structures? Always we are fancy to look at only fairly looking objects, including fairly looking human beings. So, first we'll look at the white structures, three white structures. What are they? One is bone, second is heart, third is subcutaneous tissue. Then, what is the black structure? It is nothing but lungs. In lungs, you need to look at three. What are the three? One is whether there is two lungs, one on each side, number of lungs. Second is the volume of lungs. Is it equal on both sides or not? Or aeration on both sides, whether it's equal or not. Then look at the lung parenchyma. So multiples of three. Three white things, three black things. That is all you are going to look at. If you are able to master this, you can easily interpret your X-ray in exam. So we'll try to look at the white structures. So the first X-ray on this side. Uh, Arvind, can we mute? Okay. Arvind, can we mute, please? Thank you. Okay. Now, any one of the PGs, or I should ask Dr. Geetika Pavitran to tell what exactly is there in the three X-rays. Just look at only the white structures. Geetika, unmute and then tell me, ma. Or any, yes? Or anyone else? Anyone?
First one looks like an expiratory film, sir.
Very good, but look at only the subcutaneous now. First, we'll go one by one.
Okay, sir. Okay. Subcutaneous right hand side something, some compared to left, right side something looks something big, sir.
Very good. This is normally, this is not the way in which the subcutaneous tissue is looking like. So, if you have a widening of the subcutaneous tissue, it's nothing but subcutaneous edema. Where do you get? Usually at least 2 or 3. Nephrotic syndrome, first episode when they come with like edema, this is how they are. Suppose if it is going to be a severe dengue, they are like third spacing. This is how it is going to be. Okay, very good observation, Dr. Akhilesh. Yes, in the next one, do you see anything else in the subcutaneous plane?
No, sir. Nothing. No subcutaneous plane looks.
Unilateral subcutaneous.
Yes, unilateral.
Subcutaneous.
Yes, Sahana, but you look at this thing, there is no edema, but you look at this one. This has got the consistency or the appearance similar to that of a bone. It is a calcification. Where do you get calcification in the axilla? Only in the lymph node, a calcified lymph node. Okay, this is just for you to understand. Like, don't miss out anything like this. And the last one.
Sir, left side emphysema is there, sir.
Emphysema.
Sorry, subcutaneous emphysema, sir.
Subcutaneous emphysema, it should be dark white. Okay, it should be dark in color. Subcutaneous emphysema.
Here it is, sir, white in color. Compared to right.
Good. Very good. It is unilateral. So if you are able to look at this is an ominous sign. Why ominous sign? This is going to be part of your necrotizing fasciitis. If you see an X-ray like this, you need to make sure the child is looked after well, because this is a life-threatening condition, necrotizing fasciitis. This child had to have a lot of debridement. Just for you, if you look at an X-ray like this, only unilateral, don't waste your time. Immediately call in, shift the child to ICU, because child needs better care. You need to involve the pediatric surgeon and make sure you don't lose the child. Okay. Now, next one. The right one is a normal X-ray. The next fair thing what we said is, the next white thing is bone. We look at the bones now. Anyone else who wants to answer what is there on the left side?
Bone in bone appearance. Hypercalcemia.
Bone in bone. Dinesh, thank you. But like this is the density is more.
Sir,
it is called as over-penetrated. Over-penetrated, you don't have a bone like this. If it is going to be over-penetrated, this is how it will be. This is how it will be. You look at the bone, it is not dense like this. Only it's under-penetrated. You can see the bones like this, but the heart also will be looking white. But you look at this, here the bones appear dense. This is a dense bone disease. Osteopetrosis, pyknodysostosis. Here the dense bone disease, they will present to you with anemia, sometimes like a life-threatening anemia, but it is a hematological, the child needs hematological workup too, and they can have blindness, deafness, because all the like ostium from the cranium will get stenosed and cause pressure effects too. Dense bone disease. Any doubts? Okay, I will move. And look at the density of this bone. Anyone wants to comment on the density of bone on the left side and right side?
Osteopenia.
Very good. Osteopenia is there. You are looking only at the angle of the ribs. You are not able to see the ribs properly. Here, the bones appears osteopenic. Anything else here in this side?
Cupping.
Anterior end of the ribs are
Very
dilated.
good, Dr. Gomati. Yes, definitely. There is cupping, fraying, much more than cupping and fraying. What we need to look at is the growth plate. Growth plate, the distance between the epiphysis and the diaphysis, the growth plate is widened. Not only that, take a closer look at the anterior end of the ribs. It is bulbous. It is equivalent to your rickety rosary. So it is nothing but your rickets. So don't miss out a rickets in a child's X-ray. Yes. Any of the postgraduates other than Mehta's, any findings here?
Again, that bleeding is some bleeding like thing, sir.
Akhilesh, yes, apart from Akhilesh, everyone is busy having food also and listening to this lecture, I think. But good, Akhilesh. This is not bleeding, but you see as if the anterior end is chalked out with a chalk piece. You look at the inferior angle of scapula. Someone has put a chalk diagram, a line diagram with a chalk on the inferior angle of scapula. It is a heavy metal poisoning. You can make out heavy metal poisoning even with X-ray. So, looking at the bones, don't miss out all these subtle findings. Good. This is nothing but don't get overawed if you're going to see an X-ray like this. Sometimes you can have hemivertebra. Sometimes there can be forking of the ribs. The child will have come to you with kyphosis, scoliosis, sometimes with respiratory distress, and many a times we, even including me, I examine the child without like removing the like cloths. Sometimes I do miss out a kyphosis or a scoliosis, but an X-ray tells me, oh, what I had missed in general exam, I see it in the X-ray, kyphosis, scoliosis. In these children, you may not be able to interpret the bronchovascular markings properly. Many a times you will try to think that this is a pneumonia, this is a patch of pneumonia, wherein it is nothing but you are thinking of the bronchovascular markings on that side. So be careful when you're going to interpret an lung parenchymal shadows in a child who has got a kyphoscoliosis. Okay, some breathing time for you. We had talked to you, even though I said I will not talk about basics. I have just talked to you only about basics till now. Now we'll start in a slightly faster pace. What is this? Yes, Vinodini.
Congenital diaphragmatic.
Very good. Why do you say it is a congenital diaphragmatic hernia? This is a supine epiphyllum. You are seeing the upper limbs like above 90 degrees. You are able to see the NG tube, ET tube. You are able to see the stomach shadow beneath the left diaphragm, supposed to be the left diaphragm, but you are able to see the loops of intestine in the left hemithorax. So it's a diaphragmatic hernia. Probably other questions. What is the treatment? What will be the complication? All these. Okay, blah, blah, blah. Okay. This is a child with respiratory distress. Anyone wants to answer this question? A try. Okay, I will answer. Something on the left side, but right side, you are able to see some a shadow, a cystic shadow. It is not a cystic shadow. It is part of the transverse colon which has gone into the thoracic cavity. Again, a diaphragmatic hernia, foramen of Morgagni. Then, what is it? The other one, foramen of Boktalak. Two types of foramen are there. So, you have hernia at different places. You will have X-ray showing different patterns. What is this? Anyone wants to answer? Yes, Deepana? Tell me.
The same CDH only, sir.
Same CDH.
But there is no mediation shift, sir.
Okay. Here Akhilesh
Eventration of the diaphragm.
again Gomati says this is eventration. This is eventration. Why? Because you are able to see the diaphragm. It is not up till the apex. You are able to see loops. You are not able to see the stomach separately. There is a mediastinal shift. Here you are able to see the right dome of diaphragm. The left dome of diaphragm is high up. You are able to see the loops of colon along with the stomach into the thoracic cavity. This is a eventration of the left dome of diaphragm. Management: if the child is asymptomatic, probably leave them. If the child has got tachypnea, you can try like surgical treatment, but you need to give rest to the diaphragm. Many times you will not be able to give rest to the diaphragm. Sometimes, most of the times, we do have a recurrence of the eventration. So wait and watch is usually the approach by me, but it all depends on the setup where you're working. What is this? Anyone wants to answer? Any other DNBPs apart from Metas, apart from Akhilesh?
Sir, right sided pleural effusion, sir, because right side costophrenic and cardiophrenic angles are lost, sir.
Very good try, but you see the whole of the diaphragm is here. This is the eventration of the right dome of the diaphragm. What you are seeing is the liver shadow. You are able to see the bowel shadows here. This is the eventration of the right dome of diaphragm. Okay. What is this? This is nothing but a segmental eventration. This is how it looks like. Don't think it is a mass. Don't think it is a consolidation. Don't think it is a round pneumonia. You are able to follow this. You are able to. This is the left dome of diaphragm. This is the right dome of diaphragm. This is a segmental eventration of the right dome of diaphragm. Okay. Right. All the confusions. Try to assimilate. Don't get confused. Now, what is this? Anyone wants to answer?
Coiling of
Tubes, sir.
Very good, Nagendra. Coiling of the NG tube. It is a tracheoesophageal fistula because the lungs are aerated. There is a tracheal fistula. There is also esophageal fistula because you are able to see the stomach bubble below the left dome of diaphragm. PEF. So, related questions: how do you diagnose? What treatment? How do you manage? Like probably like some syndromes associated with that. So these are the questions which you can expect along with the X-ray. This is a child who had had a surgery, correction of tracheoesophageal fistula, coming with frequent vomiting. So what is this study? Anyone else? Anyone?
Barium swallow.
Very good, Sai Varun, and I don't know who answered, but very good. This is a barium study which shows there is a stricture at the operated site. That's all. Okay, you are able to see the upper pouch which is enlarged, and you have a small stricture through which you are able to see the barium flowing through. And like, don't look at the right one. This again, there is a stricture in the operated site, but look at this stomach bubble here and look at the next bubble here. What do you call this picture as?
Double bubble.
Very good. When do you get double bubble?
Duodenal atresia.
Very good, Sri. It is a duodenal atresia. Okay. Okay. We had looked at the fair structures now. Now we look at the black structures one by one. lungs, aeration, number, aeration, and then any parenchymal shadows. Yes, anyone wants to take chance with this? A child who is growing well but has got a mild tachypnea.
Foreign body.
I can appreciate that you are thinking it is an atelectasis. Very good. But you have to look at the aeration. There is no lung on this side, whether it is an atelectasis or whether it is a like aplasia, agenesis. That means lung has not developed. If the child, if there is going to be an atelectasis, most of the time they will have some sort of respiratory issues. Here, the child is thriving well, and you are able to see the intercostal spaces. It is narrowed, similar to what you see in an atelectasis, but without that much respiratory distress. Usually, you take it if the child is otherwise doing well, it is a agenesis lung. If the child is in distress, then you know it is an atelectasis. This child has got respiratory distress with absent lung marking on one side. You have something else here also. This is a child who had had a PDA clipping. Unfortunately, once upon a time when PDA clipping, this clip was more than the size of what the thorax can hold. So it led on to atelectasis. Apart from like clipping of the PDA, it caused pressure effect on the left main bronchus and the lung collapse. So this is an atelectasis of the left lung. You look at the intercostal spaces. It is the same as the other side. This is an acute one. Only if it is a chronic one, or only if it is going to be an agenesis, there will be crowding of the intercostal spaces. Here in atelectasis, this one, there is no crowding of the intercostal spaces. So this is an atelectasis. This is most probably an agenesis. You need to do other tests to make a diagnosis. You do a flexible scopy. If you don't have a flexible scopy, how you can just doing a CT, you can make out. If you don't want the child to undergo radiation, if you have an echo, you can do an echo. Look at the pulmonary vessel size. If the pulmonary vessels are not visualized, there is no lung on that side. Very simple. Now, we look at like something else in the lungs. What is this one? Anyone wants to answer?
Left pneumothorax.
Varun, left pneumothorax. Any better answer?
Left emphysema.
Free, it is not. It is very good. It is an emphysema. You are able to see air which is more in the left hemithorax. You are able to see the bronchovascular markings in the lower aspect. You are able to see. So this means air is inside the lung and getting trapped. This is a emphysema. So what can cause an emphysema? Like how do you make out a diagnosis? How do you treat? Common things, common foreign body aspiration, getting lodged in the left main bronchus, having a valve like type of obstruction leading on to an emphysema. Okay. Now, can you do a guesswork on what these two X-rays are?
Sir, first one is congenital lobar emphysema, sir.
Very good, Akhilesh. Yes, anyone else wants to try? Which side, Akhilesh?
Left side, sir. First one, sir.
First one is left side. This side, the right X-ray. Yes, Geetika. Yes, anyone else? Okay. Yes, Sai Shashir. Okay, I will answer. You look at this X-ray, you are able to see a mediastinal shift, number one. So something is not all right in the left side. You are able to see more air in the left side. Close look at the left heart border, you are able to see something compressed. So only if it is going to be a congenital lobar emphysema, you'll have compression of the lower or upper aspect above, like where the emphysema is. Left lung has got only two lobes, upper lobe and lower lobe. If there is going to be a upper lobe emphysema, there will be compression of the left lower lobe. Now, in the same way, look at the right side X-ray. You are able to see there is something here compressed. You are seeing more air in this aspect, and again you are able to see more compressed lung on the upper aspect. This is a congenital lobar emphysema, right middle lobe. Like, just tune your eyes to looking at what abnormality can be there. This is just an eye opener. Don't think that you have not diagnosed too. It is like you are in the learning process. Kindly learn. Don't feel otherwise. So the treatment, what will be the treatment, and what will be the long-term prognosis? Once you remove the affected part, the child's prognosis is going to be good lifelong. That they will have a near life expectancy like any other kid of that age. Okay, anyone wants to try in this X-ray? Okay, here there is more air in one half of the lung. It is not limited to a lobe. It is in one lower half. You are able to see more air in the lower half. Most of the time in congenital pulmonary airway malformation, CPAM, you will have a picture like this. Okay, what is this? Two films. This child has got cough and wheeze. One is an inspiratory film, one is an expiratory film. Is there any difference in these two? Anyone wants to try? Okay. See, in inspiration, both lungs appear normal, same child. In expiration, there is air trapping in the left side. That means there is some obstruction in the left main bronchus during the expiratory flow when the child is expiring. So there is a obstruction to the left main bronchus. Common things common. It is a foreign body. When you don't have a like flexible bronchoscopy, or when you don't have access to any other diagnostics, you can ask them to do a good inspiratory film, good expiratory film whenever you have a suspicion of a foreign body.
Sir, one
Yes.
small doubt, sir.
Yes.
Sir, previously you told if there is any emphysema, there will be air trapping with bronchivascular markings, sir.
Yes.
In this expiratory film, I don't see any bronchivascular markings, sir.
Probably the way in which I had taken this X-ray was not up to the mark. All these are taken from my mobile phone and from my old digital camera. Probably previously the resolution was not good. This is a old X-ray, but probably the newer films are okay. But my camera now, this was from the old digital. You are able to see the bronchovascular markings. Probably in your computer you are not able to see that because my X-ray is not that clear. That is why. Okay, you still see bronchovascular marking. That is why it is not a pneumothorax, it is only an obstructive emphysema. Okay, right. What do you see here? Any abnormality, glaring abnormality in both these X-rays? You are able to see two lungs on either side, but the volume is less. If you have hypoplasia, this is how it looks like. Okay, if you see something like this, then what will be the next investigation? You are going to do a CT, a contrast CT, which will tell you the size of the pulmonary artery also, along with the volume, right? Any takers for these X-rays? Any straight line in the X-ray, it is atelectasis. This is a retrocardiac atelectasis. This is both lower lobe atelectasis. This is a right lower lobe atelectasis. Any straight line in X-rays, you always think in terms of an atelectasis. Okay? Anyone wants to take a try on this X-ray?
Same athletic test, sir. One straight line is there, sir.
Very good.
Right lower lobe atelectasis, sir.
Right lower lobe atelectasis is very good. Yes, anything else? Okay, a closer look will tell you in places where there should be no air, you have lot of air. This is axilla, still you see air. This is the gap between the muscle and the bone. You are still seeing air. You are able to see air in the axilla, air between the rib cage and muscle. What is it? Subcutaneous emphysema, surgical emphysema, subcutaneous emphysema. Most often it happens after a violent cough, especially in foreign bodies. Okay? The treatment is masterly inactivity. Everything gets absorbed by your blood circulation. Don't do anything. Previously, we used to do lot of incision, multiple incision, but need not do anything. Okay? Samples of subcutaneous emphysema. Look at the axilla. You are able to see the air in the axilla. You are able to see the thymus just like looking like a butterfly wing. So it is nothing but your pneumomediastinum, then subcutaneous emphysema. Okay. Another part is over. We have another 20 minutes or another 54 slides. Okay. Now we look at the lung parenchyma. Yes, any takers for this? Please answer because this
Fibrosis.
is fun. Yes,
Fibrosis.
fibrosis is there.
Multiple fluffy lesions are there, sir.
Very good.
Diagnosis terla, sir.
Diagnosis, our national
Fungal.
disease, tuberculosis. This is how it looks like. One look at the X-ray, you know this is multiple fluffy cotton wool, ill-defined opacities, both sides, with some streaks here and there, with some fibrosis also. Both these are part of tuberculosis. Most of the time, you will be seeing it this type in adolescents. Okay, adolescent TB, this is typical. Then I will tell you the first left is hilar adenopathy. This happens most often in TB. Then you have a big cavity along with node. This again happens in TB. You have a node and a pneumonia. This again happens in TB. This was taken by me in 2009 March. This is a miliary mottling. Quality is not so good, but this is a miliary mottling. So all these can come in tuberculosis. Okay. Now what do you see in this X-ray? A child with pneumonia. Normally when they give an X-ray, at least 4 or 5 important points about the particular child will be given, or they will give you 4 or 5 X-rays, just diagnose and treatment. That's all. So what is this? Yes.
Pneumatocyl, sir.
Pneumatocyl, very good. You have multiple pneumatocyls in this child. There is no mediastinal shift. So it is still within the bone, within the lung parenchyma. Necrotizing pneumonia will look like this. You'll have multiple pneumatocyls. If you want to say multiple pneumatocyls, fine. Or if you want to put this as a necrotizing pneumonia also, we'll be happy. So related questions, what antibiotics, how do you manage? Okay, right. What is this?
Hydropneumothorax.
Tobika, that is right, hydropneumothorax, but hydropneumothorax means it will be outside the lung. Then you are going to have the mediastinal shift. It is something like two people trying to sit in one chair. So there should be some push, pull, all these, no? This is, there is no push. So this is happening inside the lung. If it is happening inside the lung, what are the diagnosis or differential diagnosis?
Lung abscess.
Very good, lung abscess. Another possibility is the hydatid cyst. Okay. In North India, if you are going to see a picture like this, your first will be not lung abscess, it will be hydatid. In South India, we will almost think in terms of a lung abscess. What is this?
Round pneumonia.
Yes, Gomati, it is a round pneumonia, but round pneumonia happens in most of the time
Upper lobe.
younger children. No, in younger children, because the canals, the pores of cone and canals of Lambert are very ill developed. So this appears as if a rounded shadow. As the child grows older, as the child has more pores of cone and more canals of Lambert, that is why we have a consolidation and not a round pneumonia. But unfortunately, this child, it is not a round pneumonia. My ignorance, because I failed to diagnose an aspergillus in a CGD child. This is a aspergillosis in a CGD child, but I eventually lost the child out. Something about round shadows, like straight lines, and like fluid level in the lung parenchyma. Now, something in the airway, you may not get this, but look at this child. This child has got a mediastinal widening, but much more than that, we always try to look at the tracheobronchial tree. You may not be able to appreciate much unless I mark like this. Okay? It is narrowed. Then you look at the left main bronchus also, it is just narrowed. These are all due to mediastinal lymph nodes. This child had a endobronchial TB. Okay? Now, something to do with the airway. What do you see here?
పనికొస్తుంది కదా నీకు సెంట్రల్ గవర్నమెంట్కే కదా అది చూడంగా పెట్టు నీది కూడా.
What do you see here?
First X-ray, there is an
atelectasis.
Very good. Atelectasis, retrocardiac atelectasis. You are able to see some bronchiectasis also, but we will come to it a little bit later. This X-ray.
Bronchiectasis.
Bronchiectasis.
Okay, all mehta students will know about this child. So bronchiectasis, this is a bilateral hyperinflation. How do you call this as bronchiectasis? This is what we mean by bronchiectasis. See, you can have tram lines. Tram lines are nothing but your thickened bronchial walls. Okay, you can have tubular shadows, dilated and fluid filled bronchi, or you can have ring shadows or cystic shadows, or you can have volume loss leading to, like, due to fibrosis or shrinkage of the lung. So look at this bronchial wall thickening, but you have some mucus in the dilated bronchus, bronchosil, mucosil, this is what we call. But you know, this is not a normal X-ray. If you're able to understand that, that is fine. Now, what is this? Yes, anyone? You are able to see an opaque, nearly opaque hemithorax. This is due to fluid in the right side, right pleural fluid. In our condition, most of the time in winter time, what condition leads on to this? Nothing but your dengue, right pleural fluid. The moment you look at an X-ray like this, it is a dengue child. Okay, it's a dengue fever, but right pleural fluid is the finding. What is this? This
Left
is
subpulmonic if you.
Subpulmonary.
Yes, this is a subpulmonic fluid. Others are wondering how. There is elevation of the dome of the diaphragm. Normally, the highest point of the dome of the diaphragm will be in the middle of the diaphragm. You look at this diaphragm, the highest point is almost near the lateral chest wall. If you have a subpulmonic fluid, you will have a finding like this. It is not something like an eventuation. It is a subpulmonic fluid. This is a finding which you get in a dengue fever, sometimes in other volume overload too. And if you have a pneumonia, sometimes you will have a parapneumonic effusion. You have the fluid in the minor fissure and you have right pleural fluid. And if you have a tuberculous effusion, This is how you call it as a Ellis curve. It will be smallest in the axilla but largest in the near the diaphragm. So this is how a slowly accumulating effusion in the pleural space appears. This is a sick child's X-ray.
ఈ ఫేస్బుక్లో
Any
ఎట్లా ఇది
takers for this
చూడాలంటే
X-ray?
ఎట్లా ఇది పోతుంది
అకౌంట్ ఆల్రెడీ
అకౌంట్ ఉన్నా
మెయిల్ కావాలా అన్నీ కావాలా
You see there
డబ్బులు
is
కట్ అయితే
if there is a scoliosis, you see the widening of the intercostal spaces. You don't see any lung markings here. What condition? Child is sick. It is an
left pleural left.
empyema. Pleural effusion usually does not, what to say, cause widening of the intercostal space. Only if it is going to be a pus, and pus in the pleural space, it leads on to widening. Usually pleural fluid, yes, I accept, but it is an empyema if it is going to be a sick child. What is this?
Sir, can it be consolidations of the previous one?
Consolidation, you don't have a mediastinal shift, you won't have a scoliosis, you won't have a uniform density, the whole lung getting consolidated. If you have a whole lung getting consolidated, you will be able to see the air bronchogram.
Thank you, sir. Thank you, sir.
What is this? Yes, quick. Otherwise, everyone will be late for our dinner, no?
Increased volume on the right side of the lung.
Very good. Increased volume on the right side. Where is the volume?
Heart pushed to the left side, sir.
Heart is pushed to the left side. Okay, very good.
Congenital lobar emphysema.
Adita Wangringa. Okay. See, this is not congenital lobar emphysema. You don't see any bronchovascular marking. In between, you see some fluid, air-filled pockets. You are able to see no bronchovascular marking. You are able to see the mediastinal shift. This is a pneumothorax. You are able to see the angle filled. The fluid density you are able to see, but not jet black like outside the X-ray. Only if it is going to be a jet black like outside the chest, you can call it as a pneumothorax. Because it is in between, it is a fluid plus air, it is a pneumothorax with multiple nematode cells. Okay? After you put an ICT, this is how the child becomes. Okay, what is this?
Pneumothorax.
This is a tension pneumothorax. You see the dome of the diaphragm well down, mediastinal shift, jet black like what you see outside the chest X-ray. So this is air in the pleural cavity. This is a tension pneumothorax. What is this? This child unfortunately died, but bilateral pneumothorax, tension pneumothorax. Very rare, but most of the time it is fatal. Okay? Some breathing time. Now, we'll start once again. Any findings in this? Any takers for this?
There is an hilar lymph node present, sir.
Okay. Hilum appears clean.
No, sir. Hilar lymph adenopathy, sir.
No hilar adenopathy, but I will accept yours as adenopathy. This is a mediastinal adenopathy. You're able to see the trachea here. After that, you're not able to see the tracheal shadow, only widening of the mediastinum. Usually, this happens only with the mediastinal adenopathy. Okay. What is this? This again is a mediastinal adenopathy. If you're going to see a mediastinal adenopathy like this, most of the time it will be a life-threatening one. You see it in Hodgkin's lymphoma, you see it in leukemia. All these, it is not a cardiomegaly, it is a lymph node. Okay? Like many times you will have a confusion whether this is a heart cardiomegaly or not. This is only a cardiomegaly. When you have a heart like this, you most of the time they will have accompanying pulmonary congestion. This is how the congestion will look like. Whereas if it is only a mediastinal adenopathy, there will be no congestion. But the closest differential is going to be a cardiomegaly. Otherwise, this child had a mediastinal adenopathy, lobulated swelling on both sides of the heart. So differential, closest differential is cardiomegaly. Okay.
So how do we differentiate cardiomegaly from this mediastinal adenopathy, sir? Because we're not able to make out the heart. In this, we're making it like it's looking like a big heart-like structure, sir. In this.
Yes,
So,
very good. So the
how do
differentials
we
is going to be differential. If this is going to be like this is only mediastinal adenopathy. If
Okay,
you're
sir.
going to see a picture like this, you can say like
Looks like a more of
differential diagnosis, cardiomegaly, then like mediastinal adenopathy, differential only. Only
Okay,
when
sir.
you do other investigations, we'll be able to get to the diagnosis. Because I had treated the child, I know it is a mediastinal adenopathy. Otherwise, it is going to be a differential between mediastinal adenopathy and a cardiomegaly. The only
Okay,
thing
sir.
which I'm able to make out, this child doesn't have an increased bronchovascular marking. That is a pointer towards a mediastinal adenopathy. If it is going to be a cardiomegaly, usually they will have an increased bronchovascular marking, a pulmonary condition like this. Okay?
Thank you, sir.
Right. These are all very appearances of mediastinal mass. But here I want you to look at this. There is a obstructive hyperinflation. There is an obstructive emphysema because there is a small swelling here. Don't miss out swellings like this. Okay, I'll come to it a little bit later. Again, this is not double action by your heart. This is not a movement artifact by the heart. This is something more than what you see beyond the heart. This is a duplication cyst. Don't miss this out for a, like you don't say this is a movement artifact. Okay. I will show you the CT only, then you will be able to understand. Okay. And don't miss out any lines, any tubes, any needles like this. This is a, what is this catheter? IJV catheter. What is this endotracheal tube? What is this NG tube? So don't miss out tubes, don't miss out ETs, don't miss out vascular catheters, central lines in children, in X-ray of the children. So just X-ray, it deals with shades of gray. If it is going to be very easy, white and black, it is very easy for us to decipher. But most of the time it is shades of gray. Always read the X-ray in a X-ray lobby. Never look at it. Look at the X-ray through a tube light and try to interpret what the shadows are. Okay? Reading a chest X-ray is an art. It cannot be taught. So, if I say I've taught you X-ray, definitely not. You will start reading it once during your PG time, and after your PG, once you become a consultant, you keep on learning through your X-ray. Okay? No end to learning. I'm not going to leave you now. Okay? We'll just go through some CTs. CT, previously, we didn't have a spiral CT or a multi-detector CT. What is CT? It just uses computer and rotating X-ray machine. Whatever we do it in a chest X-ray, it is a stable X-ray machine. It does not rotate. In CT, you have rotating CT machines, and if you have multiple plates to detect the X-rays, then you have a helical CT. That we call this as a multi-detector CT, multi-slice computed tomography, multi-section CT. All these indicate it is a volume scanning. That means the whole chest, whole thorax, they are screened by the CT and then try to reconstruct the image with the help of the computer. That's all. Okay. Now, this is a child's X-ray. What you told, what one of the participants told this as a necrotizing pneumonia, multiple pneumatocysts. This is how the CT looks like. If you are going to ask for interpretation of this X-ray and CT, you look at the consolidation with treatment. This has become multiple cavities. In X-ray, there is no mediastinal shift. Still, all these cavities are there within the lung parenchyma. If you are going to see picture like this, the diagnosis is nothing but necrotizing pneumonia. So what antibiotics cover MRSA or MSSA along with strep pneumoniae? Okay, you need to treat the child intensively, otherwise child can have complications. This is a child whom I said I missed out an CGD aspergilloma round pneumonia. This was the child which I missed out. Finally, I sadly allowed the child to die before, just at the time of diagnosis only. The child came back to me, but I lost the child with a lot of complications, including CNS complications. This is how the aspergilloma will look like in CT. Any fungal infection, many times the textbooks will give you fungal ball. This is a round shadow. This will not be in the center. Usually it will be in the periphery, close to the chest cavity, close to the rib cage. And most of the time it will be rounded, unless otherwise it is liquefied. Then you will have a fungal ball. This is a shadow, a round shadow, periphery with hemoptysis in a child who is not responding. Then you need to suspect this may be a fungus. You need to do investigations to rule out a primary immune deficiency. Okay, this is a aspergillosis. Diagnosis, ultimate diagnosis, chronic granulomatous disease. This is a child who was admitted for adenoviral pneumonia, the third admission after the child got treated for adenoviral pneumonia. Child has come with a wheeze. This is how the CT will be looking at, like, even though X-ray can be like this. What is this? You have a mosaic pattern. What do you mean by a mosaic pattern? You are able to see the vessel markings here. Look at the top right one. You are able to see the bronchovascular marking. You are able to see the pulmonary artery. You are able to see, follow it up to the periphery. And but the lung parenchyma are not like the dark one. It is, you are able to see through it, but it is a ground glass appearance, mosaic pattern. All these indicates there is an evidence of interstitial pneumonia in this child. Okay, this can happen after adenoviral. We call this as a post-infectious bronchiolitis obliterans. If they are going to give a history like adenoviral pneumonia and then a CT film like this, then you call this as a post-infectious bronchiolitis obliterans, PIBO. Okay, treatment is maybe multiple treatment trials are there, but steroids form the mainstay. What is this X-ray shows? Shows a big cavity, but in CT, how does it look like? Not only one cavity, but also more than one cavity. You're able to see this. You're able to see more than one cavity. And again, this is again an image reconstruction with CT showing where all it extends in a 3D picture so that for surgical excision, it is easy for the surgeon to plan which way to go, posterior aspect or lateral aspect, wherein they have to open. This is a CPAM, congenital pulmonary airway malformation. Okay, again, a picture like this, not only a big cyst like this, you can have multiple small cysts. You have 4 different types. So this is one of the subtypes of CPAM. You are able to see multiple cystic cavities, not limited to a particular lobe. It is a CPAM. Again, this is a CPAM. So whenever you see a picture like this, first thing which should come to your mind, CPAM rather than a nematocele. Okay. Now, what does this CT show? This CT shows there is a shift of the mediastinum. This is the heart shadow. You are able to see the right lung, which is having, which is crossing the midline. This is a hyperinflated right middle lobe. There is compression of the lower lobe. Why do you say this is a lower lobe? Why not the upper lobe? Because you had already had the tracheal division in the other cuts. I'm just giving you only one cut, but this is the lower portion of the chest wherein this is nothing but your lower lobe. You have hyperinflated middle lobe, which is causing a mediastinal shift, causing compression even of the other side, left side. This is a congenital lobar emphysema.
Everywhere.
Okay, what is this? This child had an antenatally detected lung problem, but an X-ray may not pick up many a times a sequestration. X-ray may just show some amount of air trapping here, but look at the CT. In a child whom you suspect a sequestration, you should always ask for a CT angio because you need to know the feeding vessel. Even though the plain CT shows you there is some amount of air trapping here, cystic lesion here, you are able to see the aorta, a branch from the aorta supplying part of the lung. This happens, the arterial supply comes from the systemic circulation. This is nothing but your CPAM. This is your sequestration. This is a child who came with recurrent vomiting. They did the CT, they didn't know what it was, and then sent to us. This is a CT film. You are able to see some amount of pneumonia here. But what is this big round shadow with the air fluid level? It is nothing but your dilated esophagus. So we went the other way. Finally, we did the variant study to look at what is this diagnosis. What is the diagnosis?
Aklish.
Very good. Achalasia cardia is a dilated esophagus ending in a smooth tapering, smooth end. This is nothing but your achalasia cardia. Treatment is like Heller's cardiomyotomy. This happened in 2005. That is why this big long incision. Now we have come far ahead. We do only lab surgery. Nowadays they do even under endoscopic procedure. As a upper GI endoscopy, they do it as a, I forgot the name, the acronym for that. This is what I showed you. This is not a double action by the heart. I told you there is a duplication cyst. This is how a duplication cyst looks like in MRI. Okay, this is how a duplication cyst in a MRI, white shadow. This is how the mediastinum, any problem in the mediastinum, you need to do a MRI, M for M. Any problem in the mediastinum, cystic lesion, solid lesion, you ask for MRI, even though it is going to be time consuming, even though you need to have sedation for MRI, you need to go ahead and do that. Here is a child who has got a big leash of vessel from the lateral canthus, outer canthus, who has got recurrent respiratory infection showing increased bronchovascular marking in both lower zone. And what is this? CT. Signet rings, bronchoseals, air trapping, and peripheral bronchus. So what all do you see in bronchiectasis? You can have cystic lesion, cystic bronchiectasis. You can have signet rings. You're able to make out the signet ring, like it's a ring with, like it's a bronchus, dilated bronchus with a like accompanying artery. Artery was normal size, bronchus is dilated. You can have cylindrical bronchiectasis. You can have honeycombing. You can have lung cysts. You can have varicose bronchiectasis. These are the findings of bronchiectasis in CT. Bronchus visualized within 1 centimeter of pleural space, lack of tapering of the bronchus, increased bronchoarterial ratio. This is not more than 1.5. Now it is 0.8. This is an old slide like me. So I need to update. It is wrong, not 1.5. It is 0.8. Bronchial wall thickening and mucoid impaction. Where all you have this, if it is going to be bilateral upper lobe predominance, it's going to be either cystic fibrosis or allergic bronchopulmonary aspergillosis, ABPA. If it is unilateral upper lobe predominance, it is TB. If it is going to be lower lobe predominance, it is going to be a sequelae of pulmonary infection. Okay, these are the pattern and distribution. This is a child who has got a tachypnea fever more than 3 weeks, 12 years. X-ray not very clear, but what you see in the CT, it is the typical uniform pinhead size bilateral symmetrical lesion. This is nothing but your miliary mottling. Even though miliary mottling can happen with many conditions, the commonest thing is TB in our country. Uniform pinhead size bilateral symmetrical. For diagnosing miliary mottling, CT is the modality of choice, and CT only picks up the early biliary mottling. This is a child with TB. Many times you would have heard about or read about tree in bud appearance. These are all the tree in bud appearance. A bud with 2 leaves, not retiling. It is a bud with 2 leaves. That means it is an active infection. Okay, that is meant by tree in bud appearance. This happens usually with active infection like TB.
నీకు అర్థం
In
కాలే పర్సనల్
pneumonia,
ఫోన్
we
నంబర్
don't
నెట్లో ఎందుకు
usually
కొట్టుడు
resort to a CT
ఏం
on
పేరు ఆయన
day
పేరు
2 or day
గాళ్ళ
3.
సుబ్రహ్మణ్యం ఉండే కదా గాళ్ళ సుబ్రహ్మణ్యం
This is a 11 months old child with failure to thrive
కొడతారు
with
ఎవరు
increased
ఎందుకు
work of
పెడతారు
breathing
పర్సనల్ నంబరు
and
పెట్టారులేరని
suprasternal recession.
ఆయన
You look
పేరే
at
లేదు
this CT finding, you know this is not a
నువ్వు
normal lung.
వాళ్ళు
You
రెండు
don't see
100
a
మంది
normal
ఉంటారు
lung.
ఈయన
What you see, lot of
ఆ,
fibrosis,
నంబర్
lot of
కావాలా
thickening, interlobar, interlobular thickening. You are able to see ground glassing. You are able to see mosaic pattern. All these happens with ILD. One ILD you see, you will be able to make out even without the radiologist's diagnosis. This again is another form of ILD. If you know that this is not a normal lung, you are able to see the thickened interlobular septa. So once you see like this, it is an interstitial pattern, interstitial lung disease. This is a child with 5 months old child with 3 episodes of life-threatening events, needed mouth-to-mouth breathing by the mother at home and revived. This is not a CT, this is a CT film, and this is a image reconstruction of the CT. Anyone take us for interpreting the CT? படம் பார்த்து கதை சொல்லி. Look at the figure. Try to tell.
Compressing, sir.
Very good.
Vascular anomaly, something, anything.
What is the structure?
Trachea.
Very
Trachea.
good. This is very good. This is a trachea. There is a compression in the lower half of the trachea, lower fourth of the trachea. Then you do a CT angio. They wanted me to do a bronchoscopy. I said we'll do a CT angio. I refused to do a bronchoscopy. I asked them to do a CT angio. What does it show? We had already marked this as arch of aorta. It is a double aortic arch. And to give you a frightening picture, this is how it looks in color. Okay, this is a double aortic arch. You are able to make out a double aortic arch compressing the trachea like this. Okay, MRI. We don't do MRI in children most of the time for chest condition because it is more time consuming. It requires sedation and it needs more amount of money from the patient. This is a child's X-ray which shows a shadow in the mediastinum jutting towards the right side, right lung. This is an MRI. Fluid appears white. This is a duplication cyst. Okay, whether it's esophageal or bronchial, will not split our hair. This is a duplication cyst. Told you any problem in the mediastinum, resort to an MRI rather than a CT. I think we have come to the end. I'm feeling sleepy. I don't think you would have fallen asleep because many new things. This should be an eye opener for you. Don't think, oh, I didn't know this before going to exam. I felt mood spoiled looking at all these X-rays, CTs. No, you had seen a variety. So next time when you see, you will be able to definitely answer or at least like find out what the pathology or what the findings are. Once you know the findings, you will be able to make out what the probable pathologies are, give a differentials and manage the child. X-ray, you can take it in 1 second. The radiation is 0.1 millisievert. CT, you need 3 seconds to do a CT. The radiation is 3 to 4 millisievert. Means radiation, the allowed medical exposure radiation per year is 20 millisieverts. That means you can take up till 6 CTs in a year. But we know that no radiation is safe. 1 CT is equal to 30 to 40 X-rays. Use it judiciously so that like you can help the child to get a proper diagnosis and proper management. Any doubts, I'm here to answer your queries. Those who wants to go for dinner, yes, I'll spend at least 5 minutes to clarify any queries. And in chats, I don't think I have answered anything in the chat. Oh, everyone had given their answer in chats. Oh, I'm sorry, I didn't look up this. And very good. Pneumomediastinum, vascular ring. Yes, all the answers are there. Someone had, I think Nedu sir had written pneumothorax in addition to dark lung fields, increased lung volume absence, there will be collapsed lung. Yes, I forgot to mention, sir. Yes, sir, we should be able to see the collapsed lung. Sometimes the lung collapses like a tissue. It goes and sticks close to the heart. Sometimes we will not be able to see. Radiologically, it is invisible in X-ray, sir. That is why I didn't mention about the collapsed lung, but definitely we should be able to see the collapsed lung. Thank you, sir. Thanks for telling me this. Okay.
Is there any specific pattern to read CT scans, sir? Like in X-ray, we go with like we comment on the bones, then soft tissue, then the parenchyma. Anything, any specific pattern to comment on CT, sir? Or just directly we can tell the like if the project a CT scan, should we directly tell the diagnosis?
Thing is, CT scan, if you want to know, you should look at it like how you are looking at a movie. Suppose you like a movie now. What is a movie now? Latest movie? I forgot. Captain Miller, all these. You don't look at only the picture posters. You go and look at the movie as a movie in the theater, which can run for 3 hours or 2.5 hours. For you to learn CT, you need to go to the CT console and look at the CT like a movie. What you see in the films, what the patient brings is only the films. The films does not reflect every part of the disease. Only when you look at it in the CT console, you know how much you can learn or how much pathology is there.
అది
So,
స్మెల్ దాని మీద
once you finish your DMP, I wish all of you success in your exam. But once you finish your CT, when you ask for a CT, ask for a CT, a CD also along with the CT. And try to look at the CD in your computer. It will do an auto run. You'll be able to see the CT of the chest in all, in all 3 dimensions, so that you can look at it like a movie. Only then you will realize what are all the pathologies. But we don't have a separate book. What I have learned is learning from the radiologist report and looking at the CT in the CT console. This does not come in a single day. It has taken for me 25 years to tell that these are the findings. But probably I will try to start writing a book so that CT for pediatricians can be easy.
Sir, I have one small doubt, sir.
Whatever it is,
What is atelectasis and how in X-ray it will be looking, sir?
Atelectasis is nothing but lung without air. So, when there is no air in the lung appears white. And if you have an atelectasis, usually it will be lines, straight lines. You will be able to see the border like this. Okay, I will just once again, I need to turn my screen. I will tell you where exactly is this. You're able to see a collapsed lower lobe. You're able to see a straight line. You're able to see both lower lobes collapse. You're able to see a straight line or something like a concave line. So this is how an atelectasis, airless lung looks. Is it okay? Akhilesh, is it okay?
No, it's okay, sir. It's very difficult to understand, sir.
Okay, fine. You come straight, probably on Friday or Saturday, Sunday. We'll discuss. We'll try to clear. And Dr. L. Subramaniam, sir, he is going to talk to you on X-rays. So definitely, his expertise will help you to understand atelectasis much better than how I do it in a short period of time.
Sir, another one doubt, sir. Sir, if TB X-rays is means ASCII, what they will basically concentrate, sir? Or like questions what?
Treatment part, combination, fixed drug combination, side effects of any one medicine like that only. Yes.
Sir, one doubt, sir.
Yes.
How to differentiate mid-axonal masses, sir? Anterior, posterior, and kind of.
In X-ray, if you're able to make out something is wrong in the mediastinum, that's fine. Only with CT or MRI you will be able to make out. But common things like we try to correlate our anatomical knowledge, what all problems can happen in anterior mediastinum, what all tumors can come in anterior mediastinum. We just try to look at. But for you as PG, if you are going to look at any mediastinal mass, what should be the next step? Do an imaging, further imaging to find out what exactly it is, where exactly it is, base your treatment on that. But we will not go deep into how to differentiate now. If you're able to at least make out there is a mediastinal mass, that's fine.
Okay, sir. Thank you.
Anything else? Yes, I think everyone is hungry. I'm also hungry. So shall we take leave? Okay. Okay. Good night to you all.